This is a fascinating case regarding a patient who developed endocrine compromise as a result of his immunocompromised state. Patient had HIV as well as Toxoplasmosis encephalitis and subsequently developed Panhypopituitarism as well as central diabetes insipidus. Our case involves a 31-year-old male with unspecified past medical history who presented to the ED for altered mentation per family at bedside. They noted that he was recently in the hospital and discharged on oral antibiotics for brain lesions. However, they were unable to specify what the diagnosis was. On arrival, he was not following commands, hypotensive, tachycardic, tachypnic, hypothermic, severely ill-looking. Labs were notable for an elevated sodium to 157, and the CT scan showed lesions in the left thalamus, as well as the posterior left frontal and anterior left parietal lobes. Lumbar puncture revealed low glucose, elevated white count, elevated protein, and negative CSF cultures, although patient was recently on antibiotics. An MRI of the brain showed abnormal flare signal along the mammillary bodies, the optic tract, and the medial anterior thalami. The patient was discovered to have HIV, and his CD4 count was 1, and his viral load was greater than 500,000 copies. Serology was consistent with toxoplasmosis, and the patient was subsequently treated with pyrimethamine, leucovorin, and atovaquone. Later, he was started on Biktarvy for his HIV. So this case is fascinating in that it is a rare manifestation of toxoplasmosis presenting as endocrine rather than purely neurological dysfunction. It illustrates that a patient's immunocompromise can also result in severe endocrine compromise and collapse due to pituitary involvement. This should raise our index of suspicion so that patients who present with abnormal electrolytes and abnormal hormone panels should be suspected of having this rare complication.